Good evening, everyone, and thank you for joining us. My name is Carver. I am a product specialist here at Oculus. Welcome to tonight's clinical webcast, Fixing Unexpected Refractive and Premium Cataract Outcomes by Dr. Arun Gulani. You have a text box on your GoToWebinar screen where you can enter in questions. Enter your questions at any time, and we will discuss them at the end of tonight's webcast. Tonight's webcast is being recorded, so if you miss any part of it for any reason, you'll be able to catch it again later on our YouTube channel and on our website. Our speaker tonight is Dr. Gulani. Dr. Arun Gulani is a world-renowned eye surgeon, founding director of the internationally famous Gulani Vision Institute and global CEO of Gulani Surgical Suites, headquartered in Jacksonville, Florida, United States of America. Adjunct clinical professor and externship proctor at Midwestern University in Chicago, and fellowship faculty at University of Miguel Hernandez in Alicante, Spain. He's also the faculty for international researchers F1000 Prime in London. I'm excited to have such an expert in refractive and cataract surgery with us today. Dr. Gulani, take it away.
Thank you, Carver, so much for that generous introduction. I'd first like to thank Oculus for the invite and for organizing this wonderful webinar on one of my most favorite topic, which is how to fix what people call impossibles and not candidates and nightmares. These are all patients who can be corrected. So the goal for tonight's webinar for me is, as I said, my pleasure to share my own experience of over 3 decades to ensure that every ophthalmologist, optometrist, the entire eye care industry elevates where we are going with vision. And I want to make sure, I got a number of emails for the funny thing that we posted today, Ferrari and grocery and what it has to do with tonight's webinar. Well, first of all, here is the title, Fixing Unexpected Refractive and Premium Cataract Outcomes at 20 Happy using the Pentacam AXL Wave. So this is pretty much every Friday at our institute, where worldwide patients day 1 after surgery fly away, and all of these pictures that you're seeing on top of the scars and dislocated lenses or RKs and complications of LASIK, smiles, everybody who's sent over, these are all patients seeing close to 20/20 and without glasses. As you know my style of teaching, instead of showing you graphs and scattergrams that can be fudged, I show real patients because I want these patients to inspire you. These are patients from all over the world, some of the most demanding and intelligent people who've done their research before they fly to me, and yet their reactions is the only highest accountability of outcomes that I believe in. And that was my line, show me the patients. It was stolen by Jerry Maguire in his movie, Show Me the Money, 3 decades ago. And Ferrari and groceries, what did I mean by that? So most people, most surgeons, most eye doctors are using the Pentacam as the topographer. So basically they're taking a Ferrari and they're taking their Ferrari to get groceries. That's not what it was built for. Yes, it can do that function, but that's just the tip of the iceberg. The Pentacam is more than a topographer. It's actually a complete surgical planning tool, the way I use it. And you can see all these cases, and I want to share with you there is nothing impossible. Once you get through what I'm going to share tonight with all of you, the thought process, the performance, the surgical artistry, you will have no fear to tackle the most complex patients. And of course, you'll be a master at the simple and routine patients. So this has become one of the biggest practices right now at my institute, where we have a referral base from all over the world, from surgeons and eye doctors, where they've done premium lens technology surgeries, very well done in surgery, but it doesn't match the optics in the eye, and the patients are very unhappy, and they fly to come seeking opinions and corrections. I want to note at this point, what is wrongly taught, I'm going to correct that, is I have never had to remove any surgeon's lens, ever, to fix the patient's vision. And I'll show you all kinds of premium lens implants, practically every new lens implant that has been released, I have been correcting, and never had to remove the lens. You can basically fix the optics. Very rarely, countable numbers that I have to exchange the lens when it's come to me is when somebody's lens actually was broken, physically improper, that I had to exchange that, but I never had to exchange it for poor vision outcomes of any surgeon at all. So I call this taking them to the end zone. all these patients who come here and they have visual issues or complaints of vision distortions, despite surgery with their surgeons, and the surgery maybe have been done well, and the lens implant may be located well, but not optimized for the eye, and you can correct them to the end zone. So even the technologies that have been recently released, we fixed a number of these. The VUIT lens, which is a fantastic lens that I use in cases of keratoconus and irregular cornea cataracts. But this patient, for example, was referred to me very unhappy. The surgery was done well. The lens is absolutely excellent. But again, improper use in the improper eye. There was high posterior corneal astigmatism that was left in this patient. Once we fixed that, this patient was straight to 2020 and then came back for her second eye to be done by us. And now she's 2015 in both eyes without glasses. Similarly, this patient had the light adjustable lens done and had previous radial keratotomy and LASIK and PRK surgery, and was sent to us very miserable with his vision outcomes when he traveled to us. And once again, I always look for the optimized optics in these eyes. If you look at the Pentacam, you can see the total visual performance area. This E is very distorted. It's kind of blurry halos. That's what exactly his symptoms were. And once we fixed that anteriorly on the cornea with surface laser surgery, optimizing also for the posterior corneal astigmatism and the coma you see here, this patient was ecstatic with 20/20 vision. So moving forward, how do I function with our patients? And instead of fixing, I'm now going to show you my thought process for how I think about things. So here's the patient with 9 previous complications with hexagonal keratotomy, corneal ectasia, and Fuchs dystrophy, cataract. And her measurements, if you can see, are 23.5 diopter astigmatism, irregular astigmatism, with over 89.9 or 90 diopters keratometry, and mostly was given up on. Most doctors said no need to touch this eye, or let's do a triple procedure. But as you all know, doing a transplant and surgeries doesn't really bring these patients to 20/20. So that's the biggest part I want to teach you today: attitude. Doing surgery is easy. Showing surgery is easy, but the performance towards 20/20 must make you stop and think that surgical acrobatics may not be the answer. Surgical artistry to a visual endpoint is what I want to talk about here tonight. So this patient, what I did is I first put in intact rings manually around her hexagonal keratotomy cornea and brought her irregular astigmatism from 23.5 to 1.4 diopters. Now that I had made her measurable and stable, the hex K did not matter to me. I went inside the eye and did a premium toric lens cataract surgery straight to 20/25 vision. In fact, we just did her second eye, and she's 20/20 in that eye too, and freedom after 60 years. So here's how she presented. If you see the Pentacam, it has a beautiful overview mode where you can see the cataract, you can see the ectatic cornea from the hex K, very high regular astigmatism, 23.5 and 88.9 diopters keratometry. This patient, therefore, resulted beautifully in the outcomes that I wanted. This is the intact rings around the hex K, controlling the cornea, because remember, you need to make the cornea measurable before you enter the eye for cataract surgery. And then we put in a toric premium lens, no stitches as usual, topical anesthesia. Patient enjoyed those 4 minutes, and she's straight at 20/25. I'll show you briefly the video. All my videos are on YouTube, so I will not spend much time showing videos and surgeries. I want to basically share my thought process tonight. So here's a video for a quick start. I'll go a little fast for you. Referred to me following hexagonal keratotomy with corneal ectasia, vision of round fingers only, and Fuchs dystrophy, along with associated cataract and high keratometry of 88 with high irregular astigmatism of 23.5. I planned first to stabilize and make her cornea measurable in sync for future cataract surgery. Here I am using intacts, and as you can see me, I'm using her own corneal resistance to guide my intact rings in place. This was careful because I'm doing this without any sharp intervention, so I don't make mistakenly any incision that can go into the hexagonal keratotomy cuts and perforate the cornea. Again, notice these are very determined yet very careful movements of the ring, and I'm placing them so as to embrace this central unstable island. The success of this is immediately reflected in the central light reflex, if you notice, which is becoming more and more circular, and I call this the titratable concept of intact surgery. Notice again, the light reflex is now a perfect circle. I'm extremely pleased to the point that I confidently cross-link. This success is reflected in topography from 23.5 to 1.4 diopter astigmatism. Patient extremely happy, comes dressed next day to meet me. 4 months after determining stability of this cornea, so we can determine accurate cataract surgery, we proceed here. Trypan blue for the observing surgeons, viscoelastic exchange. I plan my capsular excess to be a smaller size so I can see the edges between the hex K cuts and the intact reflections, and also to maintain a good lens and capsular diaphragm. I now proceed with what we call phacoplastic, which is doing cataract surgery also in determined steps. Like you see, my phaco probe is not moving. It stays in one place while my second hand does most of the movement to maintain a stable incision. Similarly with the IA and lens insertion here. Lens is now being placed in the bag and then gently moved into its axis. Again, irrigation aspiration, well-sealed incision, further reinforced with Resure sealant, no stitch to induce any astigmatism. So here we have taken a patient who was denied her vision for 60 years. In few minutes surgeries, 4 months apart, we have restored her vision and her confidence to give her back her life, where she's come back to nursing and helping other patients. Here she is immediately after surgery, and here is my payback, seeing them smile and free to lead their life and help others. Once again, thank you for your attention. So it is important, as I will keep moving surgery out of this presentation today to make sure that it's ready for you all on the YouTubes. This surgery was also important to share with you the mindset. What did we do here? Basically, anybody who could have done a full transplant on her and removed the cataract and sent her home would not be doing something wrong. But by doing that surgery, there's no way she would be seeing 20/20 without glasses. That's important to understand. So that's the mindset I want to push, the attitude that you want vision, even though these cases are so difficult. Of course, every consent form they sign in our institute says there was no way they will see without glasses. And of course, these are complex surgeries with possible blinding issues. But the outcome is your promise to yourself, which is your attitude. You want to make them see, give them freedom. So your surgery has to be artistic, not barbaric. It cannot be a surgical show-off of acrobatics resulting in poor vision. It should be straight to vision. Now, all these cases can be corrected again. Where the Pentacam comes in handy is it's like a friend of mine in the institute. What I don't like is many doctors use it like a diagnostic. For example, they keep emailing me every day. I get emails from wonderful colleagues, but they keep asking the same questions. Dr. Gulani, this is the Pentacam. Can I do LASIK? Okay, can I do PRK? Can I put this lens? Can I put that? And I go, that's not the way to discuss these things. Look at the whole system. The beauty with this technology is shows you the whole anterior segment analysis with refraction, with the visual perception, and you can make a decision. And then surgery becomes a cakewalk. For example, here I am through 40 incision radial keratotomy. Typical in my institute, none of these patients take any anesthesia or Valium, straight topical through the 40 cut incision, bringing them to vision with the toric premium lens in situ. And that's the point. Again, bringing you through the thought process of the Pentacam analysis. Here you can see me pulling off scars from these patients, and even that is not done just as a scar. It's actually a mathematical calculation that I will discuss with you as we go further. And that's 9 diopters of irregular astigmatism coming off accurately to 20/25 vision. My thought process is exactly in this sequence: vision, then surgery, and then technology. Never do I enter the room thinking about what lens I want to put in. I always think about what the patient's vision potential is, then plan the surgery, and finally technology. And of course, the planning that I do is very, very essential for me. And that's where this technology becomes a friend with me when I do this at late nights for patients who are arriving or landing for surgery next week. So here also, what is the reason for us to do all this thought process? Well, the important thing is, one, to avoid doing something wrong, and two, to always be very, very mindful of not doing anything, as I said, barbaric. Here's a patient who flew to me for laser vision surgery, but when you look at this technology and showing you this aberrometry and the impact of the visual of concept of every part, the cornea, internal and total, you see that patch on the lens in this young 40-year-old patient. That was actually a cataract patch. So it changes your concept of what you want to do here. If someone would have done LASIK quickly without realizing, of course you can catch this on the slit lamp, but right off the bat, you understand that this patient needs a lens-based surgery. Also, the other reason I said is minimalistic intervention, which is, for example, this patient came with a scar with high irregular astigmatism. Of course, he was slated for transplant everywhere in the country. Performed my laser plastic surgery, brought him straight to 20/20, and this is what these patients do to me. This is next day. He posts this on Facebook. He's lifting 500 pounds. to show off, and it had to be done a transplant. You'd never be able to do this as a profession. So you all are aware of my pterygium concepts and how I look at ocular surface surgery, which is what I want them to be sparkling white next day. But here's a great case to show you how I work with the Pentacam in scenarios like this. This patient came to me with a very advanced pterygium right up to the pupillary area, which you can see in the topography here, with 5.7 diopters, irregular astigmatism, double vision, and she had a LASIK flap under that with her surgeon way back, what that was done in the past. Now, my dilemma became, of course, I can remove the pterygium. She's a young female, want cosmetic outcomes. But to do that, I also had to lift this massive pterygium and not damage the LASIK flap and maintain her vision. And I knew there would be a deep scar which would remain, which later I have to tackle. So we lifted off the pterygium with my sutureless amniotic technique, planned it to a point where it became just a small scar, but in the pupillary area on her LASIK flap, and then came under laser plus T-con stop, straight to vision. Now, take the different case, opposite. This is actually a patient in her late 60s with atrophic bitemporal pterygium. You can see the impact on the topography. Here, because she was not cosmetically concerned, these were not that red, these were atrophic. And though they were causing astigmatism, I could go inside the eye, do a premium cataract surgery with a toric lens implant, cancel the optical aberrations of both these pterygium, and they're not in the pupillary area, bring her to 2020. So you see how the pattern and the concept, how you change your thought process with similar scenarios based on unique systems and bring every patient to 20 happy. Here are patients of SMILE. I've been fixing a number of these patients with various complications, but here is a case to talk about where this patient underwent multiple SMILE surgeries because they had kept on showing up with myopia to their surgeon abroad, and they failed to see that the patient actually was developing a nuclear sclerosis in the eye. And that was the treatment for this patient. So the SMILE did not fail, but the concept was to look at the entire eye. Now here is a patient of keratoconus, a gentleman in his 60s, so pretty stable. The cornea was stable, no progression of cone, irregular astigmatism of 4 diopters, as you can see. Now, what we did here, because he's stable, see what I did? I'm not concerned anymore about the cornea because though he has keratoconus, it's stable, it was measurable. His doctor sent me refractions of the last 5 years, and he had a cataract. So now, even though it's a cone, to me, this is a measurable and stable astigmatism. So I went into the eye, did a toric lens. You can see the axis of the toric lens right there. Though the cornea, pre and post-op, is still showing the same astigmatism, patient is 20/25 without glasses. So you see the thought process. Here's an oral surgeon with dense scars over 30 cut RK, 15 diopters irregular astigmatism. I'll quickly show you a brief video and we'll run through this. This is a patient who's a surgeon with dense central blinding scar with crisscrossing and deep open RK cuts with high irregular astigmatism of over 15 diopters. And I plan an anterior hand lamellar keratoplasty here. So see here, the cornea is so gone. I wanted to give it strength, remove the scar, and build a foundation. Again, I don't want to do penetrating in anybody, so hand lamellar, because no machine is able to do this, no laser could do this. So I did a hand lamellar. Danger both anterior to this blade, where anything can just split open, and posterior, where I can literally go inside the eye if I make any mistake of using wrong pressure or being in the wrong plane. So you're now taking off the scar from these multiple RK incisions, again using my corneal resistance guided technique. I'm now using a donor lenticle of cornea. Pre-cut. Every time my incisions or sutures are coming out, I'm actually gathering 3 pieces of the cornea, recipient to donor, and arranging them in a closed fashion. My anti-torque suture, usually I love for it to look like a star, but this is asymmetric because of the way we had to come out in different areas. This is the pre and post. And then 3 months later, we went in with the stable cornea, toric lens, again, sutureless, topical, and straight to vision. This is a patient immediately after surgery, and these are serious people. This is an oral surgeon. Why are they reacting that way? Because you changed their lives. Could you have done a full transplant? Yes. Your resistance to do that and understanding vision and following the system with topographies, tomographies, and anterior segment analysis brought them to full freedom. And in fact, I did this on his second eye. His second eyes were equally bad, so we did the same concept for him. Was the slide not moving ahead? Here he is. If you see the sequence, this is a patient who's a surgeon with, there's a sequence, if you can see. 1, 2, 3, and there he is. Now, this is actually last week's patient. Flew in from Paris and had multiple surgeries on keratoconus. In fact, was left with hand motion vision, if you can see the image here. Someone had put in 1 intact ring and 2 keto rings and central scarring, and left with completely unmeasurable cornea with hand motion, like I said, and was told nothing should be done. In fact, this patient flew to me for surgery on the keratoconus in the right eye, not this eye. And as you know me, always I say salvage the worst eye, then touch the precious eye. So here, because there was so much distortion and the rings were visible to this patient who was miserable and given up, my plan here was not to do a visual procedure, but to do a structural procedure. If you've seen my talks on keratoconus, this falls under structural. You can see in the tomography here, you can see in the overview how the 2 rings on one area and 1 in the other, and they were all different depths. That became another issue. And this patient had been cross-linked, so another issue. But I decided to create a lamellar keratoplasty here, remove these rings carefully, split the top layer, and add a 2.5 layer to this patient. This is actually immediate post-op before he flew back. And he's getting better and better. He saw his mother's face with this eye. And it's a pleasure because I know he will see with this eye. And this is now a foundation for future vision correction techniques. So my masterclass is also based on this concept that you must understand everything about the eye as a visual optics. It's very easy to just start cutting, chopping, doing all these silly maneuvers in the eye to make videos. It makes no sense because these patients are running to me for vision. They're traveling to me having already been through these surgical acrobatics. They don't want more surgery. So when you sit down, focus on vision and the surgery will just come up to you. So technical level is all these surgeries, cataract, ICL, LASIK, SMILE, whatever things you do, cross-linking, intacts is technical level. When you do it with empathy for the patient with a consistency, that's surgeon. When you do it without any pain to the patient with complete artistic control, that's artistry. When you take it into minuets, meaning you take artistry of each level and join it together, like corneal surgery, lens-based surgery, optical in between, now you're an architect, vision architect. And if you can do this consistently, you're a maverick. So here again, how you can tackle these patients. If you can see 11.8 diopter significant.
And this is about 1 week post-surgery, and I've got probably the most problem eyes you could ever have. I've got astigmatism, I got nystagmus, myopia, keratoconus, the ocular albinism, and no one's ever wanted to work on me. But Dr. Gulani went in and did some work, and I'm seeing better than I've ever seen before. It was so cool. I told my wife I took my lens out, and for the first time in my life, my left eye could see better than my right eye. And so I'm pretty amazed, and it seems to be getting better every day.
So again, doctors who are watching, this is not as a testimonial. This is, I want you to understand how every patient who flies to me is so knowledgeable. Look at their language, pronouncing each ophthalmology word so accurately, how much pain they have been through. But my focus is vision. Anyone would have done a transplant on this case. Anyone would have given up. The answer is you don't. And that's where technology comes in. By the same context, don't look and get scared by cornea. All these patients have had RKs, 30, 40 cuts. This is my regular cases that come in, multiple surgeries, but I always look for vision. Then I start working. Now here is a case of RK who had a transplant and was again given up. Look at what we did here. Because the transplant RK, even though it was horrible with 8 diopter irregular astigmatism, at least it was stable. So looking at this topography, if you see this, and the analysis of the anterior chamber, I went in and did a cataract-based, lens-based, lensoplastic surgery straight to vision. So if you can see this concept here now, where you're seeing the corneal, internal, and total aberration, see the cornea still distorted, yet the internal correction of vision gives this patient such satisfying vision. Here's the patient actually in front as I'm talking to him. And again, watch their language. These are brilliant people, very skeptical, very intelligent, flying to me after a lot of hurt and pain. So they have no reason to smile other than the fact that their life has changed. The eye because he was also cataract age, and how we have done a no stitch premium cataract. I'm going to go a little fast here because again, time. But it's important that you can hear this. So you can see on this Pentacam AXL wave.
Missouri or anyone in ways that no one you look. I can't believe it that I came to you looking for the impossible, asking for a miracle,
You have delivered in ways that no one.
So again, docs, moving forward, patient reaction, patient knowledge, patient intelligence, very important. That's why I want you to focus. Now, let's go into my mind, okay? Let's see how I think. So here's a patient who had keratoconus, undergone premium cataract surgery, ended up with hyperopia, presbyopia, high keratometry, central scar, and the doctor had opened the capsule. Now, of course, all surgeons mentioned to him that they could surgically do amazing stuff. They could remove this lens, stitch a lens in, glue a lens in, do all those acrobatics and play with the vitreous and put it back. My point, that doesn't bring this patient to 2020. That make a great video for an academy. It doesn't bring the patient to 2020. So here's my thought process. The one surgery that I would need, so here's what I first do. I put them in my 5S system so you can see. Site scar, all of you are aware of this for the last 28 years. So the problems I had, I line it up like these pins: corneal scar, astigmatism, pseudophakia, hyperopia, high K. There's one surgery that can give me all of this, a complete strike, and that surgery is myopic laser vision surgery. But how do I do that? This patient was hyperopic. So while all visiting surgeons and fellows were watching, trying to see if I would start showing my skills and surgical abilities and what I can do with this lens, I just sat down there sharing with the patient, how do I make you myopic? And the patient also forgot the anger he had for his surgeon and just sat down there, doc, how will you make me myopic? Now, because the keratoconic eye and it's deep, I call this taking the patient to Iceland before going to Paris. So what I did here is I put a piggyback lens into this eye. 4-minute surgery, topical, and actually worsen the vision to prepare him to make him myopic. So here's where the patient has to have confidence in you. Look how I worsened the vision. But the patient is confident, even though we landed in Iceland, he's confident that I will still deliver. Plus, I have to be confident that I don't crash in Iceland because the ticket said Paris. So from there, once I made him myopic, it was easy. I did surface laser vision surgery of myopic astigmatism. I removed the scar, decreased the caves, brought straight to emetro. But this patient is 2015 and got his pilot's license back. Very important concepts. And therefore, we can even stage surgeries like these, clear the scars, go straight to premium cataract surgery with planning. Now, analyze beyond topography. The other thing I don't like is people getting paralyzed by the colors on topographies and then scaring each other and lowering patient expectations. We have to have some intelligence into it. Don't just look at the topography and less than 500 microns and go into a system of nothing can be done. For example, this patient, the myope with astigmatism, but see the astigmatism with the rule. So even though it's less than 500, this to me is a more normal cornea than this cornea. Hyperopic patient will look at the astigmatism against the rule. So even though this patient is thicker, this cornea to me is more abnormal than the first one. And that's how I decide my surgery. And you can then decide, do you go in the eye to do a lens-based surgery, on the surface surgery, or a cutting surface surgery? And that's how simple it is. Using this principle, you can also work on keratoconus with laserplasty. How? Even though the tissue you'll remove is microns, because astigmatism, if you understand the excimer laser, removes the least amount of tissue and even gives you a nice large optical zone. So in these patients where the refraction is stable and they're over 30 years of age and over 400 microns, you can do surface laser surgery, bring them to 2020, 2015 vision, and then cross-link. Don't do the other way around because you'll damage their careers. This patient is now a firefighter. So laserplasty, you'll all know my work on corneal scars where I don't do PTK ever. PTK damages vision. You have to do a refractive-based laserplasty to bring them straight to vision. And these are examples of those. And again, see how the topography moves, 5.2 to 0.4. It correlates with your vision endpoints. Scar peel in cases where the scars are above the Bowman's membrane, I call that the clown suit scars. For example, here you can see this patient. We peeled off the scar and brought this patient to 2020. It was a LASIK complication from many years ago from his surgeon. And 8 years later, when he presented for cataract, once again, we brought him to 2020. So you have to understand the concepts even into the future of intraocular surgery. GPS intact technique that I've been teaching. Intacts, you can use Kera ring, you can use Ferrara ring, whatever's available in your country, that's fine. Just something to manipulate the cornea and decrease the irregularity of the keratoconus. And you can see the immediate reaction of these patients, even under the laser while I'm working. That's why I call this my titratable technique, where these patients start responding right when you finished under the laser, still to even get up from the bed. Let's put a special ring to control your. And remember, this is not LASIK. It's a ring. And yet the vision reaction is immediate. We'll keep moving fast on the videos. So you can correct ectasia. This is 7.4 to 0.6 because that is nothing more than a surgical keratoconus. Approach it accordingly. ALK ectasia, it doesn't matter what the name of the surgery is. That's the other thing I don't want you guys to get worried about. Giving names to surgery and scaring yourself. It could be LASIK, ALK, smile, doesn't matter. Ectasia is ectasia. Fix it. So you can do these surgeries. This is the patient from Abu Dhabi we had fixed, and you can bring them to nearly zero astigmatism and improve their vision and lives without doing too many barbaric interventions. And after I put in the rings, again, as you know me, that's not the endpoint to me. If it is still measurable and there's residual refractive error, mostly astigmatism, you can still do surgery, laser vision, laser plastic, bring them to 20/20 endpoints. My concept of keratoscoliosis that you're aware of, do not cross-link before fixing the vision. So do not put cement on a bent spine. First, fix the spine. These are firefighters all in one day that were fixed and corrected to their endpoint despite keratoconus. Lamellar keratoplasty techniques, please master these techniques. It doesn't require any expensive technology. If you master these lamellar keratoplasty techniques, you basically can be a master of any LASIK smile, any lamellar surgery with no fear and full confidence to execute the 20 techniques I teach of laser vision of procedures. So anterior, non-sutured, sutured, deep anterior, posterior, and what does keratoplasty do? Lamellar keratoplasty decreases the keratometry, removes the scar, and adds tissue. It doesn't correct the astigmatism, as you note here. That's where the intacts come in. Therefore, even my DSEC surgeries, the modified thing DSECs that I've been doing for 2 decades, I actually call it RefTech, refractive DSEC, which is even in these cases that you can see sutureless and an archaic cornea, these patients can be refractively neutral in the way you correct them. By that token, you can fix patients of epikeratoplasia. Again, you see, the name of the surgery does not matter. I look at my Pentacam and go, what's going on? The cornea is thick. It has abnormal shape. It has astigmatism, high myopia. Here's what I tell the patient. I'm not even touching your cornea. This is someone else's cornea on your cornea that I'm going to ablate through with the laser and bring them straight to vision. So by this token, you can take irregular astigmatisms, fix them of any level. And please don't fear that. I just showed you a 23.5 coming down to 1.4. These are 15 coming to 1.9. So there is no limits. Don't scare yourself. Do not go and do things that are barbaric and not visually oriented. That defeats the purpose. Let's take you to another case who had 12 previous surgeries before coming over. This is a K-conus case, keratoconus, had intacts, ICL, PRK, cross-linking, PTK, lots of procedures, left with scars, ICL, and a cataract at this point, 2200 vision, miserable. Again, given no options other than transplant. If you see in the Pentacam, you can see the cataract right there. You see the rings in the cornea. Here's the good news. Even though I don't like the way the rings were done, at least they were stable. So stability being a point, I decided let's go and work on the cataract. Now, to work on the cataract, if you see the Pentacam again, I need to remove the ICL. ICL removal is very easy, as you can see, and then you head straight for cataract surgery. But because he had had 12 surgeries, I'm not trusting this cornea. So here we are in the surgery, if you see. That's all the surgery. The ICL comes out in one piece through the same incision of his previous surgeon. Check to make sure it's perfect. Do my non-moving technique, lensoplastic, reassure sealant, and I leave this patient aphakic. Aphakic. A week later, after measuring the patient, I confidently go into the toric premium lens. Again, no stitch, and bring them to 20/20. Again, very important to show the concepts, how we go through this. Take another patient here. If you see this patient had coming to me very miserable with restore lens being done in the eye. Patient's doctor did multiple PRKs, ended with high hyperopia, scars, and the patient was in a lawsuit at this point. What I did is I cleared the scar with my corneoplastic techniques, measured, brought the patient to +6 -0.5, correctable to 20/25. Now, because the posterior capsule was open and though the restored lens was in place, again, I repeat, I have never had to remove someone's lens, no matter how bad the patient's outcomes or unhappiness was when they flew to me. That's the beauty I want you to learn. Don't do a knee-jerk reaction of removing the lens and exchanging it and running into monofocals and abusing the whole visual system. Make that lens work is what I say. So the Pentacam is very important in these cases for me. It shows me how the optics works, how the aberrometry works, how the whole system with the refraction also available works, and you want to bring these patients to 20/20. So here I am in stage, putting a piggyback lens after I cleared the cornea, straight to 20/20 endpoint. That's the summary of this result. With that, I'd like to end and give you enough time to ask me questions, and I hope this inspires and absolutely energizes you to take every patient from simple to complex and never think surgery, never think technology, only think vision. Plan the vision. I showed you stages. I showed you cases who are sent to me with labels of nightmares and impossibles. Cannot accept that. Break through those labels, give these people a shot for vision, and they do see. If you can handle these cases, there is nothing to be afraid of for LASIK, SMILE, ICL, cataract, RK, scars, irregular astigmatism, keratoconus. You'll be a master of all these cases. And when the patients you plan for them, it has a tremendous impact. They become your team members. So to me, the Pentacam technology available today, the AXL Wave in particular, gives you the whole spectrum of the eye right in single visibility. You look at the thing and you absolutely start making decisions and start talking besides measuring these patients. And you can make a plan truly customized to each patient. Again, I repeat, I do not like to see surgical barbarism and surgical acrobatics, I call it, of passing stitches into the eye, hanging lenses, damaging vitreous, blood everywhere. That's not good for the patient. Those patients never see 20/20. They fly to me angry that those surgeries were even recorded by their doctors. So you always should aim for vision. That's what your patient comes to you for. Remember, again, complex cases, you're not promising 20/20 to anybody, but you're promising that to yourself, to your attitude. So master all these techniques, use the technology, as I said, use the Ferrari for more than just getting groceries, use it to its full potential, to its full depth, and you'll be amazed how you have a friend in your office that'll help you make decisions surgically. All right, with that, Dr. Gulani, all ready for questions.
All right. Thank you, Dr. Gulani. I definitely have a few questions from the audience ready for you. And just a reminder for anyone, you have that text box on your GoToWebinar screen where you can enter any questions you may have. If you're on mobile, you can just kind of simply swipe to the next screen and you can enter your questions there. If you missed any part of the webinar tonight, or if there's anything you'd like to go back and rewatch and catch the details of, you will receive a link to the recording within the next week. And all of our webinars are posted on our website in the webinar archive and on our YouTube channel. All right, first question. So for a lot of these patients, you mentioned taking an initial Pentacam scan and checking for stability, or really having that history from their previous doctor if they were referred to you. If you're taking a scan on a patient, how long do you typically wait and check for that stability?
Great question. So I like to break down everything into simple factors. There are only two things I want about the cornea: measurability and stability. So since nearly 90% of my practice is a referral practice by eye surgeons from all over, they send the patients with these preparations which they know I need, which is they will send me their refractions over a few months, over years if they have it. But when they come to me, I pretty much know at that point what I'm looking at. If in case you don't, then do your Pentacam and you will see a number of things. One, the topography. Two, the keratometry. Three, the refraction. Refraction is the most important here. Fourth, I look at lenticular changes, if that could be contributing. And number five, most important to me, is anything that has not been measured in this eye that is being missed. When you look at this whole system, you pretty much know that along with the age of the patient, you can now make intelligent judgment calls. And again, a lot of my patients fly from all over, so I'm pretty ready by the time they come to proceed with what I'm doing. In your case, if you have the luxury, they're local patients, you can even wait 3 months, 6 months. I tell the patients, I'm in no rush. So if anybody asks me, patient, doctor, how long will I have to wait? I said, I'm in no rush. Until I get stability on you, I'm not proceeding. So the patients also understand how seriously you take this. But for all of you listening, there is no parameter I want you to follow. That's the point. Today, I want to break down your shackles, things that shackle you, and you decrease your desire and the patient's expectation. Don't do that. Just feel free, feel strong. Look at it and you want stability. If you can't see stability, call them in 3 months back. It's fine. And look at it. Ask their optometrist, ask their doctor, whichever place they live in, hey, can you please send me refractions of the last few years? Or can you refract this patient once more before they fly back? Absolutely fine.
Perfect. You have a lot of patients with corneal complications. When you're addressing those corneal complications, you kind of mentioned handling those first? Do you wait for the eye to recover and scan the eye and have a separate cataract surgery, or do you do it all at once? And in that case, how do you determine what lens power to use with such an unusual cornea?
Lovely. So you noticed I never did it all at once, right? I'm totally against what I call cocktails. So if y'all can even take down the words I'm using tonight, it'll change your life. I hate cocktails. If you mix surgeries up, it just reveals to me that you're not cognitive or empathetic about visual endpoints because you just mix things up. Everything you do to the eye changes the refraction and the vision. So if you see me in all the cases I showed you waiting 3 months, 4 months, and like I said again, I would wait 7 months if I had to, if I don't see stability. No patient can push me to do surgery. So once I have done my work, what is the first thing I did with the cornea? Another thing I want to break your shackle. Don't give it names. Keratoconus, keratophakia. Don't give it names if it scares you. Look at the cornea, even if it has 40 cuts. I showed you doing cataract through that. No big deal. Disregard the cuts and the scars. When surgeons watch me, I tell them, don't look at the scar and the corneal scar. When you're looking at RK, don't look at the RK. Look at the potential beyond that, because whichever surgeon did the RK did it with a good intention. I never believed in RK. I never decided to do any. Today it's become one of the biggest practice for me of fixing RK problem. But whoever did it with a good intention of vision. So that cornea still works. Believe in that. Now, measuring the lens power, that's a whole different 4-hour course we can go over later. Today, my main thing is to give you a mindset that even if the cornea is completely scarred, as long as it is measurable and stable, you can enter the eye. Don't do the other thing too. Do not enter the eye when you're not confident about the measurability of the cornea, because then you have knowingly entered with an improper lens power.
Perfect. Get that cornea measurable and stable. Perfect.
Cool. Measurable, stable. That's all.
Perfect. For your international patients, how do you address the dry eye disease, which is a common complication for cataract surgery outcomes in your practice, especially when so many of your patients travel to see them for such a short amount of time?
So it's very intense what I do. First of all, if you've seen me in my talks, presentations before, I refract each one myself, no matter what data I get from any surgeon. And the surgeons referring over have to speak to me before the patient comes. I speak to the patient before they travel a month before. So if I feel there is something needed, they get it done before they reach here, or I make them stay that long here. If they have to stay for 2 weeks, so be it. I'm very cognizant to the expense of traveling and staying, but then I make my decision. So can the doctor I trust to do a certain dry eye procedure or treat something before coming here? If not, come here and stay for 2 weeks instead of 1 week. So yes, I do take care of those things. Now, another thing I'm going to stress on all of you: do not make a big thing out of small things. Dry eye is very important, but here your focus is perfecting through the scars. So even though it is important, don't deprive the patient of that major mountain of an impact. Let the molehills go. Be very focused in what you're doing. So you can. In many cases, I've done the dry eye treatment even 2 days before I proceed to corneal surgery or intraocular a week later. And it's very doable. Next.
Perfect. All right. Do you use relaxing incisions to manipulate corneal optics?
I do, but not in these cases at all. Remember again how I speak, all right? Very important. Clarify all these concepts that are confused by many doctors who are teaching. Don't do anything inaccurate on an accurate surgery. Let me repeat that for you. When you're using a premium lens in the eye, you don't want to do an inaccurate surgery. LRI, even with my hands, which I'm very proud of my results, I still don't do it on these cases because you're inducing an inaccuracy. You don't want that. So in those cases, if you do need to, do a laser vision surgery. Do a toric lens. Toric lens is an absolute must for astigmatism. It's very accurate. Don't let anyone tell you it doesn't work in this or that cornea. It works all the time. Every tennis racket works. Must know how to play. Cannot blame the racket. So do use LRI if that's the only thing you have, but it is an inaccurate surgery compared to the accurate optics of a premium lens technology.
Perfect. On that note, do you still use toric lenses even when the front surface corneal astigmatism and the back surface corneal astigmatism aren't in line?
Again, a very big myth, mostly by non-surgeons who are speaking about this. If you realize, if you saw the corneas, I showed you nearly 100% of them had toric lenses going in. If it wasn't working, I would have someone complaining at this point. These patients are blown away. So I repeat, please do not get mesmerized by molehills that are magnified by people who don't even do surgery. Posterior corneal astigmatism is important, but first, attack the mountains. Cannot give up. 100% of my practice is premium. 100% I do use toric with any astigmatism in the eye. It's important. Please do not underestimate astigmatism. If you tackle all these cases but are scared and use a monofocal lens or a lens that doesn't fix everything, you've deprived the patient of the chance to see. Cannot do that. The whole point of tonight's talk is you go all blown, ready to perform.
Perfect. That's a wonderful philosophy. And, I really hope
Nothing less,
people are
doctor.
taking it
Nothing.
to
Let
heart.
me repeat the statement if I may interrupt, Carver. A surgeon's inability should not become a patient's disability. Please remember this. You must go in prepared. Don't just show up in surgery, and do not tell me you did 30 cases. I will ask you for the name of every patient. And I don't want to see your statistics. I don't want to see surgical videos. I always ask, show me the patient. Is the patient dancing during surgery while you're in their eye doing cataract? Is the patient smiling and chatting under topical anesthesia without Valium? If not, you need to improve. If the patient is not dancing after surgery, you need to improve. Your advertising makes no difference. The patient talking is all that matters. So if you go in with that mentality, I promise you, your surgical skills will improve automatically because you're focused on vision. Your surgery has to become fantastic subconsciously. Go ahead, please, Carver.
This might be beyond the scope of the time we have in tonight's presentation, but how do you calculate the surfaces or the your laser plastic surgeries?
By refraction. I refract these patients. The minute they land, it shocks them. I'm refracting them for hours with my streak retinoscope. The Pentacam has a unique feature in the AXL wave. It actually gives you a refraction. And though I have all these technologies in my institute, I also manually refract through the scars, through RK cuts, through keratoconus. That is what my patients will tell you when they see you. That's absolutely, I've sweat sometimes. I spend hours and hours trying to find what I call my vision potential. So I repeat, do not call any cornea irregular. Please note this other statement I'll make for you. Irregular cornea is a diagnosis as sensitive and intelligent as flu or a stomach upset. It basically means you really didn't make a diagnosis. There is no such thing as an irregular cornea. Refract these patients. Once you find the vision potential, get to work. Look at your Pentacams, look at the anterior segment analysis, and plan vision. I showed you these patients. These are 40 cut RKs. These are 23.5 diopter irregular astigmatism. There are scars. These are patients who are told nothing can be done. And these are not ordinary people off the street. They researched for years before flying. You saw them speaking ophthalmology. So I want you to please get addicted to the patient reactions. Do not call these things irregulars and difficult. Start street retinoscopy because a refractive surgeon must know how to refract. Next, Gaurav.
All right. I think this will be the final question of the night, and it is kind of digging into your approach, kind of once again, that surgeon's philosophy and that really kind of philosophy of caring for your patient. Why salvage the worst eye first and then address the precious eye?
Well, simple. Safety, right? Your confidence is one thing, and I love that. And I want you to have the attitude as eye doctors because you're giving people the most sensitive sense, but cannot get cocky, cannot undermine safety. Because the precious eye is something that the patient's relying on for the rest of their life, you first want to salvage, I call it, any drop you can from the worst eye. Once you get that eye done, and I call it that eye is in our hand, now you go to the precious eye and bring it to perfection and relieve this patient for life. If you do the opposite, here's the issues. First of all, you're working on a precious eye, and absolutely, I want you to be confident. But now, if something happens to the precious eye, now, while that eye is healing or whatever, recovering or something, your worst eye cannot help. And now is not the time to go after the worst eye. You'll have two eyes in the frying pan. So safety is very important. Again, unique to my practice, we do not advertise, don't do deals with anybody. There's absolute purity in my love for the patients. And that's why I keep showing them to inspire my colleagues in the industry. But safety first. When you plan for safety, plan for long term, and plan with an accuracy model. What I say is, If you see somebody in a car accident and you see all the bones of the leg are crushed, my attitude is not, hey, honey, thank God you're alive. My attitude is, how can I make you run in the Olympics with that broken leg? So if you keep that attitude, you will change the way you approach any patient. You will stop getting scared and scaring your patients or lowering expectations. You will walk into your institute or clinics tomorrow, even taking a simple myo, go through my 5S system, look at what else the patient has. In a cataract patient, look at what else is wrong. Fix it all, and fix it with a bravado. Again, I repeat, you're not guaranteeing the patient 2020. You're guaranteeing yourself that you're going to perform at that level. That will change you. And for those who think surgery gets better by doing hundreds and hundreds, I'm completely opposite as a teacher. I want you to visualize the vision. Your surgery automatically will become artistry. Is doctors, I don't want you to call yourself a LASIK, cataract, smile, or corneal surgeon. You are a vision corrective surgeon. You must know 40 techniques to make people see. Only then can you be a master chef performing with unique vision recipes. Do not hype up the lens technologies and stuff. Those are just ingredients. Use this technology to become a master chef of vision. So you must know how to do all these 40 techniques from cornea to lens. I don't mean glaucoma, retina, or plastics. I'm talking vision corrective 40 techniques. Then and only then you're a comprehensive vision corrective surgeon with supreme confidence, and you can tackle anything of your patients and take care of your colleagues' complications with equal bravado and safety. That's my parting shot for you guys tonight.
All right. Thank you so much to everyone who sent in questions, and I want to thank each and every one of you for joining us tonight. Thank you so much, Dr. Gulani.
Thank you so much, Kara, for having me tonight.